who will introduce our esteemed speaker, and we will start the recording the session now. Thanks, everyone.
Hi, everyone. Thanks so much for joining us today. My name is Erin Graham, and I'm the Waterloo Wellington Stroke Navigator. I'm so pleased to welcome Paula Chidwick, our hospital ethicist for Grand River Hospital, to speak to us today about ethics in stroke care. Dr. Paula Chidwick is the Director of Research and Corporate Ethics at William Osler Health System and the founding director of the Osler's Ethics Quality Improvement Lab. She has a PhD in philosophy, specializing in bioethics from the University of Guelph, and a fellowship in clinical ethics from the University of Toronto Joint Centre for Bioethics. She provides ethics services to healthcare organizations throughout Ontario and across Canada. We are so very lucky to have Paula as our ethicist right here at Grand River Hospital. Please join me in welcoming Paula as she speaks with us this afternoon about ethical issues in stroke care.
Thank you. Thank you, Tammy, and thank you, Erin, for setting this opportunity up. And I'm very pleased to be here today to talk to you about ethical issues in stroke care, and in particular, the role of the substitute decision maker. So I'm going to move these slides along. Okay, did that work? No. Okay, there we go. So in preparing for this event, I received questions from quite a few of you, and they were very good questions. So what I've done is really frame the bulk of this presentation around the questions that have been raised. So there were questions around consent capacity and substitute decision making, and with a particular focus on issues related to patients with aphasia. And I think in this context, this is a really great question. So I hope we, in the rest of this presentation, what I'm going to do is run through those questions and provide some thoughts and some answers. And I also am able to pause and take questions as we go along. So I'll leave it to Tammy and Erin to just interrupt me, which is just fine, and I won't be able to monitor the chat. And then we can sort of get through, and in addition, really connect with what's most on your mind around these issues. All right, so I want to begin by saying that role clarity is something that can help us go quite a long way in sorting through the issues that come up. And I'm struck by how often this comes up when I listen to the WHO pressers on COVID-19, that each one of us has a role in our response to the pandemic. And we need to know what that is, and then inhabit that role. And I think that if you can keep this in the back of your mind, when it comes to decision-making and ethical decision-making, each one of us has a role. And when we get clear on what that is, the decision-making also moves along smoothly. So there's a role for physicians, families, there's a role for patients and clients, and each one is slightly different. So I think to begin, and I want to start with what decisions require consent under the Healthcare Consent Act. And there are three areas of decisions that require consent. And the Healthcare Consent Act is a law that was acclaimed in 1996. And it really outlines the way in which we have to conduct ourselves ethically and legally when we're just we are discharging our duties, our responsibilities between ourselves as healthcare providers and clients and patients. So we can treat people because they rely on us to follow the rules and obligations laid out in this act. And so it describes the three areas that require consent. There's lots of decisions that people make, but not all have to meet this bar. So I'll just move this along. So the three areas that the Healthcare Consent Act says we need consent for are treatment decisions. So those are done for therapeutic, preventative, palliative, diagnostic, cosmetic, or other health-related purposes. Admission to long-term care facilities are regulated facilities. So not every place that somebody is discharged to is regulated. Only one requires consent as described in the Healthcare Consent Act, the long-term care. And we also need consent for personal assisted services. So some of this, some decisions don't require consent. And these do not require the same bar. We cannot ask somebody to meet the same bar under the Healthcare Consent Act when it's not required. So we can't ask somebody to do extra and have the ability to understand when they don't have to, by law, be required to be able to make decisions with that very high bar. And we don't need consent for emergencies. So people can treat you in a case of emergency without your permission. You don't need consent to leave the hospital. You don't need consent to go to retirement home. You need somebody to agree to go, but not consent the way we think of it in the Healthcare Consent Act. And also going home does not require consent. And taking alternative medicines doesn't require consent as we think of it under the Act if we're not proposing it. So we'll come back to this towards the end of the presentation when we look at issues related to discharge and some of the questions that came up for that. So onward. So when can a client or patient make decisions about themselves? And I would just say always, and we should always turn to the patient and client. First, they're always presumed capable. So, there's lots of experience and you may know your clients very well or your patients very well, and it may be that they're clearly not capable, but it's just a good habit to always turn back to the patient or the client and presume they're capable. And if possible, they should be making all the decisions. And the second thing to keep in mind is to consider asking what their home language is and providing an interpreter if in fact they don't have English as a home language, and using an interpreter to use their home language. That's often an issue where we may believe somebody is not capable because they're not responding, but it's because we're not speaking the language that they understand the best way. So capacity, and you are capable to make decisions. If you meet this test, you have the ability to understand situations and the ability to appreciate consequences of making a decision about the situations. So this is a pretty key slide for some of the questions that have come up and that have been raised around aphasia. While you presume capacity, you also must be confident that this is happening, that the person who you're talking to has the ability to understand the situation and the ability to appreciate the consequences of making a decision about that situation. So you can have cognitive deficits and still have this ability. You can have challenges speaking, mental illness, or psychiatric issues and still be capable. So that you have any of those particular characteristics doesn't necessarily mean you're incapable. You are capable if you have this test, this ability. So this will come up again and we'll touch on it often. So who and how does one determine capacity for decision making? So it's always the practitioner proposing the plan that evaluates capacity. So if you're proposing treatment, placement, or personal assisted services, you are the one evaluating capacity. And remember that capacity is the ability to understand the situation and the ability to appreciate the consequences of making that decision. It's not that you can speak. It's not that you are depressed. It is your ability to understand and appreciate. Sometimes people consider getting capacity evaluations done by assessors. And while those may be helpful, they are good for one point in time, and it's still the responsibility of the practitioner proposing the plan to consider what the assessor has said, because it is the person proposing the plan that has to evaluate capacity, and it would be for one point in time. So how do you evaluate capacity when there is aphasia, communication challenges, or cognitive issues? So this was a common question asked and on the minds of many. So thank you for raising it. Again, it goes back to the ability to understand and the ability to appreciate when making a decision about the situation. And so communication tools would be key in a situation like this, and consideration of prior expressed wishes. So if you can't know this about someone, then i.e. do they have the ability to understand and appreciate, then you may not be able to turn to them. I mean, there's a minimum obligation to consider communication tools. You would never, and that's why I suggest an interpreter sometimes. You would never want somebody to not make a decision about what happens to them because they did not have access to an interpreter. And if they did, they'd be able to communicate clearly. So if there are ways to communicate and there are tools to do so, that's a minimum obligation for this kind of decision making. And that we would always ask about any prior expressed wishes, because that can be meaningful in terms of sorting out what the patient or client would want in a situation like this if we're not able to know through a conversation with that person. So the next question, can a family member make decisions for patients or clients when the patient or client is capable? So sometimes it's easier to talk to somebody who's there and is fresh and it's easy to communicate, and I see it happening all the time. But when it comes to consent, this is not considered valid consent. And I'll show you where that's stated. So sometimes we get, there's two scenarios where we are talking to the family member present or the substitute decision maker because it's just convenient and easy. And sometimes the client or patient herself would say, just talk to my daughter, or just talk to my son, just talk to this person, and what we call defer to a family member. And that's also very common, but neither is considered valid consent. And it states this clearly in the college policy for the College for Physicians and Surgeons, where the practitioner proposing a treatment plan is a physician, but that can also fall to somebody else. If you are a nurse or another practitioner proposing a treatment plan. So you would want to ensure that your college also what they say about this, and I would imagine it's consistent. So you cannot defer consent as a patient if you're capable. And you have to, as a practitioner proposing a plan, communicate the risks and benefits in order for that decision to be informed and considered valid. So in this frequently asked questions document, it really nicely outlines the circumstances of trying to work with a capable patient who is also at the same time saying, don't talk to me, talk to somebody else.
Paula, there's just a comment in the chat.
Sure.
Just before you move along, you were speaking about aphasia. Somebody has said they would also suggest involving speech language pathology to help reveal patients with aphasia's capacity and assist the team with this.
Yes, that's a great comment. I agree completely. Yeah, absolutely. Okay, thank you for that, Erin. So can a patient or client refuse a practitioner's treatment plan? So the answer to this is anytime, because as you know, if you don't have consent or valid consent, it would be assault to treat somebody. So you need to get consent. And if you don't have it and somebody refuses your treatment plan, you don't have consent to provide it. So you just have to step back. And the only way that this person would get that treatment would be in a situation where it's an emergency. So when does a substitute decision maker get involved in decision making? So this is the substitute decision makers only get involved when the client or the patient is incapable of making a decision based on their ability to understand and appreciate. And it could be that the client or patient is incapable sometimes, and then other times they are capable. So in other words, capacity can fluctuate, and there is no requirement that a client or patient be capable all the time. Each decision that requires consent is a specific decision, and it's only you obtain consent at a specific time. You don't have to be capable all the time, and if you're not capable for part of the time, it does not mean that you're incapable. So what if the patient or client is not capable to consent? Who do you turn to and when? So there's a list provided to us through the Healthcare Consent Act, and they have created a hierarchy where they list out all the people who are decision makers for somebody who is not incapable. And our duty and obligation is to go from the top to the bottom. We don't pick anybody that we prefer on this list. You have to start with the top person, and I'll come back to this and sort of run through what each one is, because before we do that, we need to do one more thing for the patient or client, and we need to consider whether that person wants to challenge the finding of incapacity. So patients or clients must be told that they are found incapable, and they need to be also be given a chance to challenge that finding of incapacity through a Form A, that's the name of the form, through the Consent and Capacity Board. So this is not a personal or performance issue for practitioners. When somebody questions your finding of incapacity, or the person you've just found incapable questions what you've said, everyone has the right to challenge the finding of incapacity. if they can and if they want to. And we should always afford them this opportunity to, because it's about their right to decide if they are capable, what happens to their bodies. And we should welcome anybody who wants to challenge this finding. And what I have found is that when this happens, when somebody challenges it, it really provides an opportunity for the team, the practitioner proposing, if that's a physician, and a neutral third party, the consent and capacity board, to be really clear that before they take away the right for a patient or client to make a decision about themselves because they are incapable, they have this opportunity to challenge that. And if they're found incapable at the consent and capacity board, then you can go forward with confidence. And if they are found capable, you can also go forward with confidence. And that everybody's rights, in particular the patient or client, have been upheld. So back to this hierarchy, the substitute decision maker, the highest on the hierarchy, is a guardian, and a guardian has to show up with, court appointed court papers that say this person is the legal authority to give or refuse consent for this person, and that's over time. The next highest is the power of attorney for personal care. And this one in particular it could be somebody that's not on this hierarchy. And we'll talk about that in a couple of slides to come. After that, you could have a representative. So somebody who didn't get a power of attorney together, or doesn't have a family member, or would like somebody, there's a dispute between family members, one of them can ask to be appointed the representative. So they'd be higher, third highest. And then you go down the hierarchy looking for the spouse or partner, the child or parent, the brother or sister, and so on. And the last person on this list is the public guardian and trustee. So how often does a person have to be assessed to be determined not to have capacity? So each time there is a new decision, you would presume the capacity of the person, you would turn to them. Capacity is measured for each decision, and incapacity is not global. Can a patient have capacity for some decisions and not for other decisions? So yes, and this could be because of time and also because of the nature of the decision. So whenever possible, you should always, the best decision is the one somebody makes for themselves. And so if somebody fluctuates within a day and has good times in the day and not so good times in the day, talk to them about important treatment decisions or placement decisions when they're having a good time in the day to make decisions. Find out when that is, or wait for that opportunity and then seek consent. But there's no requirement, as I mentioned before, that you be capable all the time. And for each decision, some may be more complex than others. And while somebody may not be capable of consenting to a complex surgery because they may not understand the situation or appreciate, they may be able to make other kinds of more straightforward treatment decisions. So again, where the rule of thumb is, wherever possible, if somebody has a moment in a day or a week where they're capable, seek consent for those decisions at that time. So if there were two equal standing substitute decision makers and they disagreed on the plan of care, whose direction do you take? So sometimes we spend quite a lot of time with substitute decision makers of equal standing. So you could have a brother and a sister, children are all equal, and we do conflict resolution with families and try and bring the families to arrive at a common decision for the patient or client. And quite a lot of time and energy and effort is made in these directions. And what I found helpful is to approach family members, and sometimes it's really clear that they have different views, and just remind them that it's okay for them to disagree, but that you would give them a certain amount of time to make a decision about the treatment plan that's been proposed. And then if they're not able to make that decision, you'll go down the hierarchy. And the next on the for this kind of scenario is that you go to the public guardian and trustee. And I think when you give this information to them at the beginning of the process, they quickly can set aside sort of lifelong standing conflicts between each other, which is not a role for you to resolve, and make a decision together in the interests of the client or the patient. If they don't know that you can go down the hierarchy, this kind of decision making can be dragged out for weeks and weeks and weeks. And it really puts the patient or client at a disadvantage and possibly in harm's way, because they're not getting a care plan implemented in a timely way. So I reaffirm to family members and equally standing substitute decision makers that it's okay, they can't make a decision, but we will be going down the hierarchy at this time. So what if you can't ever reach the substitute decision maker? They're just not available. They're not picking up the phone. And this is another time where you just need to go down the hierarchy and go to the next person on the list and seek consent, and also leave that substitute decision maker a voicemail to say that, you have to be willing, capable, and available to be a substitute decision maker. You're not available at this time. That's okay. We will be going down the hierarchy. And often when that happens, when you leave that voicemail, or even tell them the very first time you meet them that this is how this is the kind of relationship we have to have. You have to be available. You have to be capable and willing to make a decision. They often will answer the phone and call you back. Sometimes you have to just go down the hierarchy, which is just fine as well. But sometimes we wait an awful long time until they are willing. Who do you turn to if both the patient and the partner are not capable? This is, again, something that can happen when you've got an elderly couple. And again, it's a requirement to be as a substitute decision maker to be capable. And if that person is not capable, you have to go down the hierarchy. And if you set them aside and say, sorry, Mrs. Smith, I don't think you understand and appreciate it's the substitute decision maker. You have to be capable to be the substitute decision maker. So I'm going to set you aside and go to your daughter. The substitute decision maker actually cannot appeal this decision. And that's different from what we talked about when the patient or client appeals through the Form A. The substitute decision maker has no recourse. So it's actually it's a powerful tool in the toolbox, and it's very rarely used. But sometimes it's necessary to, and I hear healthcare professionals say, I don't think she understands. I don't think she appreciates the decisions at all. And when you're saying that to yourself, you're probably dealing with somebody who's not capable, and your duty is to set them aside and go down the hierarchy. Now, if they regain their capacity later on, you can include them in decision making. So can a patient or client choose their own substitute decision maker? So yes, they can. And this person is called a power of attorney for personal care. And this is a really valuable opportunity for a patient or client when they don't trust anybody on the hierarchy to follow their wishes when they are incapable. And the process for that is pretty straightforward. There's a power of attorney kit, and you need a couple of witnesses. And you don't have to be capable in this situation the way you have to be capable to make a treatment decision, have the ability to understand and appreciate. For this, you only need to be able to recognize the person that you're appointing as the power of attorney for personal care. And you can point to them and recognize them. It's a little different for property, power of attorney of property. You actually have to know about your financial situation. For the purposes of this presentation, I'll focus on the power of attorney for personal care. So again, this is a golden opportunity often for patients and clients who already know that their family is not going to follow their wishes. And there's disagreement there. And you probably notice that everybody on the hierarchy is in some way a relative of yours. And some of us have lots of people in our family who we trust and who, we've made promise in one way or another, follow this wish or that wish. But many of us don't have that. And so the power of attorney for personal care is a golden opportunity and to offer a client or patient to say, is there somebody that you trust that will follow your wishes when you're incapable? And you can appoint that person. This is something that I'm getting an unstable message, so I'll keep my eye out to see if I freeze. So when somebody is saying to you, I know my daughter won't follow my wishes, she already told me, this would be a golden opportunity for somebody to use this power of attorney kit and to appoint somebody who would act as a decision maker when they are incapable. Another question often that comes up is whether a friend can be a substitute decision maker. And unfortunately, there's nobody listed in the hierarchy, friend. And so, but the friend could use the Form C application with the consent and capacity board and be appointed a representative. So that's, again, another really helpful, proactive, upstream opportunity for patients and clients that, have specific wishes, want to choose somebody they trust, and it could be a friend or a neighbor, and that person may be willing to be appointed. If they're appointed if they are incapable, but they could be appointed using the power of attorney kit if they are capable and they agree to be a decision maker. So can a substitute decision maker override the wishes of a patient at end of life? So it is the job of a substitute decision maker to interpret the wishes that a patient or client had at end of life. And sometimes those wishes may not apply to the circumstances. And so that would be the prerogative of the substitute decision maker to interpret. But otherwise, usually they ought not to override those wishes or change those wishes. Of course, they can't change the wishes. In my own life, 27 years ago, my mom had sort of a critical incident, and in her advance directive, she said, "I never want to be on a ventilator." And I think what she meant by that was that she never wanted to be sort of sustained on life support And so like indefinitely on a ventilator. And so she needed a ventilator. And if I had interpreted that wish in the advance directive to mean never ever, then she wouldn't have been put on a ventilator and she would have died. But she was put on a ventilator despite what she wrote in her advance directive, and she's lived and she's still alive at age 90. So it was my job to interpret the wish, and what I interpreted at the time was, I don't think this is what she meant, and that's the job of the substitute decision maker. And I think you know, one of the most successful things that that you can do is to help substitute decision makers know that kind of information, that there is a specific role for them. It's not about what they want for their loved one. It's really what the loved one has said in a wish and your interpretation of that wish at the time, or considerations of best interests. And I can't emphasize this more, that helping substitute decision makers understand what their role is, and provide them information in a brochure. The very first time you meet them will be a huge upstream opportunity for you that will save you hours of downstream potential misunderstanding and conflict, when they know what their role is, to be it willing, capable, and available, to that they will only be a decision maker when the patient or client is incapable. When if they know of a prior express wish, they would need to interpret that wish and then consider best interests. And the small sort of information, small bits of information go a long way to preventing misunderstanding downstream, months later and sometimes years later.
Paula,
yeah,
sorry to interrupt you. There's just a few questions in the chat here.
Okay.
So one of them is actually in regards to POA for property. Someone just commented that in their experience, when an individual uses the POA kit to appoint someone as POA for property, when the POA brings the document to the bank, they're often met with resistance, as bank staff will say they have no way to verify its authenticity. Can the bank actually do this and get pushback?
Yeah. So I agree, this happens all the time. And can a bank do that? Well, I think they do it all the time. Sorry, the postman or somebody's just walked by. So, I mean, ideally, all I can say is just keep going back and keep, trying to push it forward, and encouraging them to keep taking this information back. Sometimes, as a courtesy, we will. I remember a case once where the bank pushed back and they said, we need this piece of information. And the substitute decision maker asked if we were able to provide it. And it was a reasonable request, easy to, provide. So we did, as a courtesy. But, this kind of thing can happen, and banks all have, slightly different rules, and sometimes they're, if they're risk averse, they're just going to say, no, nothing can happen. And it just requires more and more work on the side of the substitute decision maker. And really the best opportunity is an upstream opportunity to get a lot of this in place before that person becomes incapable. And so whatever opportunity there is for that, And if they are oblivious that they need to get this in place and they're still capable, but you know that at some point in the future, maybe the near future, they will be incapable, it might be something to mention to them. Do you have this in order? Because it makes it very much easier for everybody.
Okay, thank you, Paula. And the next question is, does a POA document have to be notarized?
No, it doesn't. Those are just, the requirement is 2 witnesses. You know, every time I go to my lawyer for the last will and testament, that will, that has to be, you know, notarized. But this is when you are incapable but alive. It only requires 2 witnesses, but your lawyers will say, hey, let's do this. They asked me to, and they'll charge you for it, but it doesn't have to be done that way.
Okay. Someone else is asking, for clarification purposes, can you please expand on what you mentioned about the person who is appointing the POA, that they do not need to be capable when appointing, rather they just need to recognize the person they are appointing? Did I understand that correctly? While in hospital, we often have patients who wish to appoint or complete POA documentation right after an acute stroke, for instance, where cognitive or communication impairments are apparent. Is this reasonable for the team to support or discourage the patient appointing a POA at that point in time? Thank you.
Great questions, everybody. So I would say to that so you have understood it correctly. Like there's never a wrong time to appoint somebody who you trust will follow your wishes. And sometimes, as you have described, it's not in ideal conditions. But again, it goes back to some of the remarks I made right at the beginning. We can't impose on a person a higher bar about making a decision where it's not legally required to do so. So for appointing a power of attorney for personal care, you need to be able to recognize the person who you're saying, yes, I want that person. And you know, I've seen the whole gamut of different states that somebody might be in. And sometimes they just aren't able to do it. And sometimes they actually can't sign. They just put an X, which is fine too, because you're testifying that they've made a mark, or they've made this would be a signature if they could write. So the bar isn't the same as a treatment decision or placement decision. It is about recognizing somebody, and that you do that, and that you try and sign the document. And if none of those things are there, then that person cannot appoint. But if they are, and it's always better if somebody can appoint someone that they trust, I would seize that opportunity. The only time you don't have to, you should consider not doing it, is if you tried everything and the person herself can't actually do that, recognize the person, or complete the task.
Hey, there's lots of questions here, so I'm going to read the next one. Are you okay with that, Paula, or did you want to keep going?
No, please interrupt. I'm just going to text my husband and ask him to come and get the dogs.
No problem. Someone is asking if you could please clarify why representative appointed by consent and capacity board sits higher than spouse or partner on the hierarchy.
Okay, if I've heard you, they're asking about, so that's a great question. I mean, that was conceived of by the architects of the law. So I'm just thinking, that the representative is somebody who, just a second here. I'm just going to close my window, it might help. All right. So it might have something to do with creating an opportunity for somebody to say, you know, I don't agree with everything that, you know, I'm equal on the hierarchy, and I want to have an opportunity to separate myself from this person on the hierarchy that I happen to be with, and have a chance to say, I'm the best person to make a decision in this case. I think that's the best I can do on that question.
Okay, that's a tough one. That's okay. Someone else is asking, how long is it appropriate to wait to reach an SDM before moving to the next person in the hierarchy in a non-urgent but still pressing matter, for example, swallowing assessment?
So I would say use your judgment. If the moment that it becomes potentially harmful or even remotely harmful to the patient or client, then that's the time to move on, because the law said, you know, this person has to be, the substitute decision maker has to be willing, capable, and available. And it didn't say, and we can wait, and we should wait as long as it takes for them to be ready. It's a big responsibility to be a substitute decision maker, because you need to be available and willing to make decisions, because the person you're making decisions for shouldn't have to wait for you. The duty is really you have to them as a substitute decision maker. So no harm or disadvantage should ever come because you're waiting for somebody. And sometimes people just aren't able to make a decision. They're not willing to make a decision. It's too difficult. And it helps to give them permission to say, it's okay to step aside. It's okay to step down. If you waited, you know, a year, they still wouldn't make a decision because they're not ever going to make a decision. And waiting isn't, we should never wait. If a patient or client needs something, then they need it. And you need to give a reasonable amount of time and then move on. And it's something to explain to the substitute decision makers when you first meet them, so they know what's happening and they understand what their role is.
Okay. And last question for now, anyway. Can the PG&T be appointed POA if patient does not want their hierarchy SDM to make decisions and they have no one else to appoint?
So, sorry. So just to clarify, can the PG&T be appointed?
Yeah, I think that's what they're asking. They're saying POA, but I think they mean yes. Can the PG&T become involved if the patient doesn't want the person or people who are next on the hierarchy to make decisions?
And there's nobody else, and there's no friends. And yeah, that's a great question. And I've actually asked the PG&T this several times. They will consider doing that. They will consider being a decision maker if there is nobody else.
Mm-hmm. Yeah. Okay. Thank you,
Paula. You need some runway for that one, though, because it does take some time. They don't automatically go there to be appointed. It needs to be something where there's no other choice for this person.
Perfect. Thank you.
All right. Thank you. Okay, so onward. What do you do when the team has a difference of opinion? You know, having a difference of opinion clinically is I think just fine. It's the sign for me of robust medical interactions, and having a difference of opinion, I think, results in a more thoughtful, you know, treatment plan being laid out. So I think that that's a good thing. However, if if your difference is in your opinion of perceptions of risk, or how somebody should live their life, like one way or another way, then those are largely irrelevant. So it would be like deciding or weighing in on what car a patient or client should buy. It's their choice in the end. So the risk somebody wants to live with is their prerogative. And so role clarity here is key, and that it would be really important to know what's important to the patient or client in a situation like this. So seeing your role as a healthcare provider, weighing in on clinical issues, and how those land for the patient or client is really knowing what their wishes, values, and beliefs are, and we shouldn't really have opinions on those. So what should happen when the family and patient disagree? So I would say something very similar to what I just said around a difference in opinion between a team and a client. So if it's around, in this case, they would have very little role unless they were a substitute decision maker. And again, really trying to redirect the issues to the patient or client, and or the wishes that they held and beliefs and values to guide decision making. So the opinions of family members about the risk somebody might want to take, or the way somebody else might in their family want to live, are not as important as what the patient or client would want for herself or himself or themselves.
We have another question, Paula.
Okay.
Can a patient decide that they do not want someone in the hierarchy to act as SDM at the time that they do not have capacity? For example, someone who has dementia with paranoia, who no longer trusts their child to make their decisions.
No, they may have run out of, unless they're capable and they're able to appoint a power of attorney about somebody, with somebody that they trust, and you believe that they recognize that person, they're going to be out of luck. And again, this is where I think any upstream opportunity that you have, when you recognize, like you can tell as a professional where this person might be at a certain point in the future, and it includes them being incapable, everything that you can do to help them prepare upstream to appoint people, etc., is well worth it. There'll be a point where somebody is incapable and they won't be making decisions for themselves, and they won't be able to appoint, and they won't be happy with the person either. So that's a very vulnerable person when they're in that state. And it's important that we also, as healthcare professionals, are making sure that we're all meeting our obligations, that individual who is making decisions is doing it on prior expressed wishes or best interests, and that they're not proposing treatment plans, that we are the ones proposing the treatment plans, and that we're seeking consent. And everything that we've talked about is how the decisions are being made. So no harm results from a situation like that, where there's very little that you can do to change it.
Okay, thank you.
Okay. So you've heard me say a couple of times that we should, base decisions on prior expressed wishes. And, it makes me think of, people don't plan to have a stroke, and often people don't write down their wishes. and then suddenly they're in a situation where communication is more difficult and maybe impossible. And so you don't actually get to benefit from knowing what a prior expressed wish is to guide you in decision making. And when the law was conceived, they said, well, okay, so what else should we consider? And then they said, well, if there is no wish, nothing was written down, and there's nothing applicable, then we have to consider best interests. And best interest is defined in the Act. And for those who are curious, you can look it up for the very precise wording, but just in general, they're determined by considering the values and beliefs of the patient or client, and those decisions that promote benefit and reduce decline for that person. So when you're considering decisions and treatment decisions, if there's some benefit, if it reduces decline, etc., then that could be it would meet this test of being in the best interests of that person. So I'm just gonna, okay, I'm seeing up there. So we've got a bit of time. So what is required for consent regarding a feeding tube? So again, this would be a decision that would need to be informed, and consent would need to be obtained from the patient or client if they're capable. And it would also need to be proposed by a practitioner and be indicated. So there's lots of literature on feeding tubes and feeding tubes at end of life. And there's lots of correlation between feeding tubes at end of life and benefit and no benefit, that there's often not added benefit at end of life. And so a couple of things to keep in mind with this. Families never get to propose feeding tubes, but they do it all the time. And so again, seizing any opportunities that we have to provide role clarity around their role is, if the patient is not capable, to provide consent to the proposed plan by the practitioner. And if the feeding tube is indicated, then it would be proposed and it'd be on the table. But if it's not, then it's not on the table, and they don't have to provide consent for it, but it's never their role to put it on the table. And there's a common false dichotomy created sometimes in our language. And I would encourage everyone to very thoughtfully consider, the words and sentences they use when they talk about feeding tubes. Sometimes, rightly or wrongly, substitute decision makers and families believe that if we feed a patient, then they'll live. And if they don't, they will die. And this is just an untrue false dichotomy. So it could be the case at end of life that whether you feed them or not, they will die. It's just how they will die. And so we have to be careful we don't give the impression that if we feed them, then they'll live, because they will die. And then they'll wonder why they did, because they were fed. And it was never true that if they were fed, they would live. So sometimes they're going to die. It's whether they'll die with a feeding tube or not. So just a few thoughts to consider for feeding tubes on that. So what do you do when the team is struggling with a substitute decision maker's decision? So again, this might be a case where you actually did not propose the plan, the family did, and you are struggling with that. If this is about going home, consider that this person was never going to live in the hospital forever anyway. They were always going to live. And we have to sort of remind ourselves that everybody who arrives at the hospital leaves the hospital. So I would sort of step back if you're struggling and just do that role clarity. Is there an opportunity to clarify what treatment plan has been proposed? Is it in line with the client or patient's wishes? And is it in their best interests? So can a substitute decision maker name somebody else in their absence? No, they can't. And this is something great to tell them right away when you first meet them, that you will be going down the hierarchy. So nobody can appoint somebody to make a decision for them when they're not capable except that person. So when the substitute decision maker isn't available, then they can't be the substitute decision maker, and you have to go down the hierarchy. But nobody who's a substitute decision maker will know that unless we tell them. So that's really good information to tell them when you first meet them. What do you do when substitute decision maker is not following incapable person's wishes? So this is an opportunity potentially to go to the consent and capacity board and challenge them on that. But consider that the substitute decision maker may have interpreted the wish in a way that makes sense to what they know about the person, and that is completely legitimate decision making. So it's not for us to interpret the wish of our patient or client. It's the job of the substitute decision maker. So they can make decisions sometimes that surprise us, because we've interpreted the wish slightly differently, just in our own mind, in the background. It's not our role to do that, but it can take us by surprise sometimes. So what happens when there is no substitute decision maker? And I think somebody raised this already in the questions. This is when the healthcare professional will go to the public guardian and trustee. Okay, so I have just a few more slides that I'll touch on around going home and issues at discharge. So to start, just want to remind you, actually, I'm just going to go back for a second, that everyone who comes to the hospital leaves the hospital because the hospital is not housing. So that is always the plan for somebody. And in fact, you don't need consent to leave the hospital, as mentioned earlier, or to go to a retirement home, or to go home. And so that has to be in the front of our mind always, that when somebody decides this is, I'm done, I'm going to leave, our attention should be focused on ensuring, to the extent that we can through our consent process, through personal assisted services or other services that may require consent, that they land well, that they leave, but they land as best in the best possible scenario. We don't have any authority to keep them because we don't feel comfortable. So this question was asked around whether the Healthcare Consent Act can be used against somebody's will when discharging. MRP feels that they're not capable of managing on their own in the community. So you can't use the act this way. And there are actually no provisions for healthcare professionals in any act that I know to keep somebody from leaving the building. On the Mental Health Act, you can use a Form 1, but there needs to be psychiatric issues involved on that. So this doesn't mean that, I'm not saying that, we don't have duties, but our duties are not, we can keep them against their will. There's very few people in our society that have that much power to keep you against your will. And there are all kinds of, laws and rules and rights around that process. So we can't just sort of adopt this because we don't feel comfortable about somebody's decision to leave a place where they've tried to access healthcare. So the duties and obligations, I think, need to focus on what can we put in place, what supports can we connect this person to, can we refer to, that can help them when they leave the building, and how do we encourage them to do that? So how do teams manage when there is risk associated with discharging patients and the patient is capable? So again, this is an opportunity to clarify those risks, and not try and talk them out of the risk, but to ensure that they have the best understanding. You can add that you think it's a lot of risk, but again, your opinion is not that relevant. It's really what the person is willing to take on, and that you will respect those decisions that they make, and that they accept the risks, and that you again focus your opportunity to support them, your time and energy and acumen to connect them with supports they may be willing to take on, and other referrals that could support them in a situation where they're going to live at high risk.
Paula, just to pause, if you can go back to that slide for one moment. When you're saying, how do teams manage when there is risk associated with discharging patients and the patient is capable? What do you mean by that? Capable to what?
Well, well, I guess to clarify, just that they have their wits about them, that they may be capable of making treatment decisions while they're in the hospital, but they can leave. You can also be in the same situation and be incapable of making treatment decisions. I guess it's a bit, I mean, to clarify that, they could leave just because they want to, because you don't need consent to leave. So if you're worried about that, or if a plan is being put together for discharge, and there's risks associated with this, and people are refusing support, or you have to make sure that and refusing support that might require consent, then you just need to respect that and ensure that they understand and accept the risks.
Okay, thanks.
Thank you. So what do you do when a patient or client has impaired cognition but is still capable to make a poor decision to discharge home alone? So again, I'll invoke the same caveat. You don't need to be capable to go home, but folks can feel that this is just not a good scenario. It's not going to end well. There's concern about what might happen when you're at home, and while I appreciate that all of that is true, the best focus of our energy is to figure out how to support that person around the decision that they have the right to make, and outline the potential risks and support so that they can make informed decisions for those that require consent. Just 2 or 3 more slides, and then we'll be open for discussion. So is there such a thing as too high a risk to go home? When a team has worries about what might happen, and I think this is related to this question too. What do they do when they make risky decisions? The best thing that you can do is, for those decisions that require consent or are treatment decisions, that they're informed. And for those decisions that they're making, like going home, that they're also informed of the risks that you perceive. They don't need to agree about those risks. And I think it's always worth saying that to your clients and patients, that you're not going to try and change their mind, that you will respect their wishes, that they want to be back home. I can't tell you how many people that I know only want to be at home, and that they want to decline at home. They want to die at home. They don't want to be in a strange place when they're that sick, and they don't want to be in the hospital, or they don't want to be placed somewhere. So there's a lot of desire to be at home, and the way we can support that, I hope, evolves and changes and becomes more sophisticated. But I think it starts in part with our capacity to just see what's possible for them in terms of resources they might be able to access, people who can come in and support them in and explain that there will be a difference in how they'll live, and it might look like this, and that this could help with this and that, and they get a picture of without feeling that they need to change their mind. They get a picture of how living at home could be like, and that they could change their mind about that. They could add supports in about that. I'll end with a story about a call I got. There was an elderly couple, and the children, the 4 children of this elderly couple called, and they said, "We have a serious problem here. My mother's the substitute decision maker and she's unfit. You need to find a way to remove her, because my dad is just disheveled." And he had come in to the emergency department, and he clearly hadn't changed his clothes in a long time, and he had lost a lot of weight, and he was dehydrated, lots of things going on. And they admitted him, and there were lots of things they could do, so they did all those things, and he started to sort of become more stable, but they were really worried. And so they said, "You need to come and talk to our mother." I said, "Sure." So I found a time to go, and I walked into the room, and I could see that he was struggling, that he may have needed to be in the hospital before he was there, or something needed to be different. And I turned to her, and I wanted to just make sure that she was the right substitute decision maker. And then the second thing I asked her was whether he'd ever written down his wishes or had a power of attorney for personal care created. And she says, "Oh yes, he did that." And she had a copy in her purse, and so she produced it. And everything that happened to him was the result of following his wishes, that he never wanted to end up in the hospital, in a care home, and that he had, when he was capable, made her very, carefully promise to do all these things. If I don't want to eat, don't make me eat. If I don't want to change my clothes or bathe, don't make me do it. And she promised. And so he trusted her, and she actually followed through. What she didn't know was that there was potential supports for her at home when she couldn't cope with all of that, and that they could do it differently, that he could be at home and they could have support and they could do this. And there was a whole lot of things that they decided to, in the end, together, they decided to bring into the home so that they could live better when they were at home and as he declined. So, people, I think there's a lot of opportunity when people make these risky decisions to both affirm them and then help them over time understand what their opportunity to live at risk, but also live with everything that is available to them to minimize that if they wish to. All right, so I'm going to pause there, and maybe I'll stop sharing my slides so I can see faces. Thank you very much.
Thank you, Paula, very much. There are a few questions here, so I'm aware of the time. We may not get to every single one, but we will do our best. Just trying to see where we left off, because some people were putting questions directly to me and some people were putting them to everyone.
I think we're going to unmute people as well now. So if people have questions they want to ask, feel free to ask your question, and we will certainly work through the ones that are in the chat as well.
One of the questions, Paula, was that if an allied health professional received verbal information from a physician, that the physician received consent for the treatment that the allied professional was proposing, is that enough for consent, or does the allied person need to obtain that consent themselves?
I think if they're the ones proposing it, and has somebody outlined the risks and benefits? So the person obtaining consent has to be confident that the risks and benefits have been explained to this person. That they would do that is ideal. If somebody else does that and they said, yes, they've agreed, can they rely on that? Is that the question?
Yes. Yeah. Can they use that, or do they need to go back and get their own consent directly from the patient, I think is what they mean. And that person can correct me though if I'm misunderstanding the question.
I mean, it feels like it would be reasonable to do so, but you'd have to be absolutely certain that the conversation that you would have has taken place by somebody else. So, I mean, I think if you want to have this airtight, then you would need to have the conversation yourself. So you're sort of asking. Patients can't actually defer consent. Can a healthcare professional defer consent? So probably the most sensible way to respond to that is that you should have the conversations yourself. Now, I think you could probably go to your college to see if that's addressed in a Q&A somewhere, to see if somebody else can propose the treatment plan. I think you can delegate it for a team member to do. Yes, you can do that. So you'd have to be confident that that conversation was discussed amongst the team, and then one person on the team went and got it. If that was a physician, then you could rely on that.
Okay. Does anyone else want to speak up and ask Paula their question, or do you just want me to go through the chat?
I have a quick question. This has talked a lot about, which is very helpful, the legal side of things and what you're legally required to do in terms of who is the kind of last word on these decisions. But I wanted to ask a little bit about, I know in the US, there's been a lot of advocacy recently for a framework of supported decision-making for people who have cognitive impairment, where you involve their POA or their substitute decision maker in a conversation where the goal is to kind of get a consensus and feel that everybody's involved in the decision making to help support that person who might have, that kind of borderline capacity or the ability to make some decisions, but not the more complex ones, rather than just always going around that person or going to somebody else. Is there kind of discussion of that in Canada? Are there any frameworks or recommendations for using a supported decision-making framework in Canada?
Yeah, thanks for that. I think you're raising something that is very important, because what I've noticed, as you've suggested too, that the way people make decisions often is done not autonomously, like alone, but in groups where they are supported by family members or by advocates or by other community members. And I think as a general rule, encouraging people to participate in decision-making, like inviting people, is there anybody you would like to have at this meeting? Do you have a support system that wants to be part of this process? All of those things are possible. But again, to be very clear, the role clarity in the decision making. So sometimes our response when people say, just let my daughter make all the decisions, is to encourage them to participate in the process that they would usually make or undergo to make their decisions, which doesn't really have to involve us, because it could be different for each person. And then they can go off and talk about it together, have other people involved in weighing in, and people can provide opinions, etc. But that's something that they're doing because that's what's meaningful to them. And then somebody, the patient or the client, comes back and says, okay, I've been through my process and this is the decision. And that they know their role in decision making, so that it doesn't become a situation where 4 people think they're making a decision about somebody and there's no legal authority to do that. You always have to go back to the person for consent. And so they can participate in a collaborative model and include all kinds of different ways of doing it and people. But at the end of the day, they have to bring you that decision, and you have to have provided the information about the risks and benefits to ensure that you've got valid consent. So what I think you can do both, and you can both meet your legal and ethical obligations, and you can respect the different decision-making models that inevitably people will have. And we can respect that and meet our other obligations, I believe.
Great, thank you so much.
Okay, Erin, I think we have about 5 minutes left. So if there's a couple other questions, you can probably see what we can get through.
Sure. Somebody was asking that if some doctors ask the nurse to provide phone verification from an SDM, what is the nurse's responsibility?
What does phone verification mean? Like get consent?
I don't know if the person who asked that question wants to clarify. That's what I'm thinking they mean, but.
So if it's been discussed as a team, and can the nurse do X, but the nurse, you can't, sometimes this happens with, physicians might ask somebody, a surgeon might ask a hospitalist to get consent for a surgery, just let me know. And you can't do that. It needs to be, unless it's the team delegating, then it really needs to be the practitioner evaluating capacity, etc. So with regard to the nurse, if she's part of the team, and she's been delegated to do that, then, and there's risks and benefits and so on. But the practitioner, the person responsible for evaluating capacity and obtaining consent, is the practitioner proposing the plan.
Okay, thank you. Oh, there's a new, goodness me. Sorry, there's so many. I'm just trying to make sure I go back to the right one. Some of these you answered already. I'm kind of just screening them, to be honest. You answered them in your presentation. Actually, I think we're caught up. Did anyone have any questions that they have not put in the chat? I think we have like 2 minutes left still, if there are any questions. No, we might be done. You guys are awesome at keeping us on track. Oh, it's saying one new message here. Let me quick read this. Oh, someone said that was very informative. Thank you so kindly for this great presentation.
You're most welcome. Thanks for all the great questions. It was really a pleasure to try and put a presentation together around the things that you're thinking about and having a chance to know what that is. So I really appreciated the questions, and And thank you for Tammy and Aaron for setting it up that way, and letting the audience sort of really direct the focus of the presentation. So thank you for that.
Well, Paula, on behalf of Central South, I'd really like to thank you very much. It was a very informative presentation, obviously very needed, as all of the questions and how interactive it was with our attendees. So thank you so much. Just a reminder to everyone that we will be sending you out a link following this with the certificate of attendance and the evaluation survey link. And then we will post this on the Central South website. It usually takes a couple days to get uploaded. So feel free to go and review the meeting from today.
People are asking specifically about the slides. Are we sharing the recording or the slides? I wasn't sure.
We were going to share the recording. Paula, would we have permission to share this, post the slides on the Central South website?
Sure, I can send you the deck, no problem.
Okay, yeah, so good question. Thank you. We're happy to do that then. Thanks, Paula.
Thank you, Paula. Thanks everybody for joining us today.
Thank you very much.
Thank you. Bye, everyone.